Good morning. Thanks very much for the opportunity to speak to you all today. What I want to talk about is the role of the anaesthetic and acute pain management in the care of patients with cancer. Particularly, I'm going to be a bit more focused on patients who've got solid tumours requiring surgery. I think it's pertinent for us to comment that most patients, when they do have a solid tumour and they're requiring surgery, they tend to be pretty focused on who their surgeon is and what day it's going to be done on. There tends to be not so much of a focus on the anaesthetic side of things or the acute pain side of things. And what I want to do is give you a little bit of insight into the sort of thoughts that are going through our minds in 2017 and the sorts of things that are important. Now, where's Richie? Despite his healthy mop of hair, Richie Ma is actually the same vintage as me. Don't let that deceive you. When we started training, which was in the last century, this is what our anaesthetic machines looked like. They now look like this. They're a very advanced piece of machinery. What we've done in anaesthesia in the last 20 years is we've really refined things that used to be that airway, breathing, circulation and drugs. Those four things caused us a lot of calamity for our patients. It was often things that we look back on now of being, I can't believe that used to cause us problems. We've pretty much well eliminated most of those major problems with airway, breathing, circulation and drugs, so that we're now in the refinement phase. So we're refining things. We're doing things such as, there's an association now between lighter anaesthetics and better outcomes for patients. So we're just refining things. And refining things in terms of patients undergoing cancer surgery is the sort of area that we're focusing in on now. So that's what I want to talk a little bit about with you. As some background information, we do need to square away what exactly we're trying to manage and why we're trying to do that. So I just want to go through some background stuff. The first thing is, let's just think about why exactly we want to try and manage acute pain. It may be quite obvious, but unless you sit down and think about it, you may miss some of the important points. So three major points I want to talk about. The first is that pain relief is a universal or a basic human right. And that's a concept that was proposed and very firmly brought forward by Professor Michael Cousins, who set up this pain unit. How you go exactly bringing about that acute pain management for a patient is extremely complex, and we could spend days talking about the various options and modalities. What we do instead, or what I'm going to do instead, is just summarise those different options into the little catchphrase we use these days of you need to take a psychosocial, biological approach to managing patients' pain. But it's very complicated. And the second reason we're going to try and manage someone's acute pain is that we want to try and reduce morbidity and mortality. We do know that certain therapies, when used to manage acute pain, will reduce death rates and will reduce complications. I want to point out the caveat to that, though, is that's all predominantly being shown with something called a thoracic epidural, which I'll talk a little bit about more of today. So when we're talking about other modalities that aren't thoracic epidurals and talking about the benefits of them, it may well be that it's an appropriate extrapolation from the evidence with thoracic epidurals. It may be that it's inappropriate extrapolation. So just bear that in mind when you're thinking about the benefits of what you're doing for the patient. The third reason why I want to try and manage acute pain is that all chronic pain starts somewhere, and it usually, if you look at patients who present to chronic pain clinics, have got pain more than 3 months. If you look at their histories, the first few days after the insult, whatever it was that's causing their pain, they're reporting high levels of unrelieved pain. And given what we know about the neurobiology of pain, we're assuming that because you're having intense nociceptive signal travelling through the spinal cord, you're getting central sensitisation. That central sensitisation is not reworking itself or restoring itself back to normal, and that's why the patients are going on to get chronic pain. That's a very tempting link to make. We do need to be a little bit careful. We're not sure if it's chicken and egg. Maybe people are going to get chronic pain after whatever injury. The sign of them having acute pain is just a marker of the process that's going on in their bodies. So just bear all that in mind. It's quite amazing that it was only really quite recently that Apfelbaum published his seminal paper that really brought home to us just how much pain people do have after surgery. And it was a ridiculously simple study he did. He just, he didn't do it, he got his researchers to do it, obviously. Unpaid medical students usually it is. Ringing up 1,000 odd patients post-surgery and asking them about their pain experiences in hospital. And what they found was actually quite staggering, that in the red there, up to a third of patients had really quite severe levels of pain post-surgery. Yeah, all right. Good aspect is 2/3 of them were in this euphemistic, as my colleagues call it. They're doing okay after surgery, crew. What I want to point out with this pie chart, it's a really important concept for us to understand. These are the patients I'm worried about as a pain management specialist. These are the ones that I get called about on a Saturday night or a Sunday morning when everyone else is tucked up in bed. These are the ones that we're struggling with. Unfortunately, most of our modalities that are coming out, or the things that are being spruiked by drug company X or device company Y, are helping these patients. They're only helping them to a moderate degree anyway. They're changing the VAS scores by 1 or 2. So just bear that in mind when you're looking at new things going, okay, I'm going to help all these patients with this new technique or new whatever, but what am I going to do with these patients? I still need something that's helpful for these patients because these are the ones we're worried about. And we'll talk a little bit about that today. I want to just talk about some common misconceptions that are causing us real problems in 2017 in the Western world. We'll sort of lead into a bit more about this problem with the opioid epidemic, but this is one of the misconceptions that pervades through the medical community and even the lay community, that there's a direct correlation between how much opioid particularly, or how much drug you give to someone, and how much analgesia you give someone. Therefore, i.e. that if you're giving 20 milligrams of morphine, that's good. But if you give 40, that's twice as good as giving 20. In the lower ranges, that may well be quite true, but where it doesn't hold is when you start getting out and this on the right-hand side of the graph, then that concept doesn't hold. And what you need to be thinking more is framing it more like this. So on the y-axis, I've now changed analgesia to pain. Okay, so yes, we do see a ceiling effect that as you increase your drug dose, you control pain, but what I really want you to point out is out here on the right-hand side of the graph, that if you've got people who are needing high doses of particularly opioids, that's a sign that your patients are in a lot of pain. That's not something to be boastful of, that's something to be concerned about. Why are my patients in pain? What's going on? If it's a repetitious occurrence, a particular group of patients, then that's your chance to look back and go, okay, we need to try and look at something to try and fix these patients, okay? But we do need to swing our whole concepts, because that concept is contributing for sure to the opioid epidemic, which hopefully many of you, well, it's not something that you're proud of, but hopefully many of you are aware of this opioid epidemic. This is just one of the many different graphs that you'll see that demonstrate this problem of the opioid epidemic, which is particularly hit very hard in the US at the moment, in the order of 10,000 deaths per annum as a result of prescription opioid misuse, and this graph just shows what's been going on in the US. 10-year period, this is the prescribing of prescription opioids, kilograms per 10,000 people. There are two other graphs there that totally mirror that quadrupling of prescribing, and that's deaths associated with prescription opioid prescribing and admissions to opioid detoxification programs. So we're seeing a lot of collateral damage as a result of our overprescribing of opioids, and that's particularly in the US. Australia is a condensed version of that. One of the things that we're going to try and really try and tackle, I guess, moving forward is the overprescribing opioids. But to do that, you're going to encounter people who will challenge you and say, the classic that you'll encounter is that, well, you're being mean to your patients, you need to give them more morphine. So we need to make sure that we're really clear about what we're actually trying to treat. And one of the stumbling blocks I see a lot of the time is that patients particularly, but even clinicians, don't actually understand what pain is, what it is that we're trying to treat. And so it's very important that we just have a little chat about what actually pain is and what I'm trying to treat. So the IASP definition of pain is these three key words: unpleasant sensory and emotional experience. I want those to be logged into your brain for the rest of the talk. Unpleasant sensory and emotional. I'm going to use a very simple diagram to try and explain why I think that is important for you to differentiate out. So there's a central nervous system, there's a brain and a spine. So we've got nociceptions, so that's the sensory component. So that's just the nociceptors interpreting noxious stimuli, carrying that noxious stimuli up to the thalamus. We then have integration with the emotive component, so that's the limbic system and such forth. That then produces what I'm concerned about, or we as pain specialists are concerned about, this experience of pain, an unpleasant sensory and emotional experience. when I do a VAS score, verbal analog score or visual analog score, I'm trying to get this whole component, the sensory and the emotional component. Okay, that's what I'm after. Unfortunately, patients have not been told the definition of pain or don't understand VAS scores, and even doctors often don't understand truly a pain score. So what do I mean by this? Well, this is the example of the patient who's in recovery, who the nurses had to give 50 to 60 milligrams of IV morphine to. When they wake them up, the patient says, I've got a pain score of 10 out of 10. That patient doesn't have a pain score of 10 out of 10. They have a nociception score of 10 out of 10. What they're trying to tell the nurse is, I'm feeling a lot of stuff, okay? That's what they're interpreting the nurse is asking them. They don't understand that they're supposed to be telling the nurse how much unpleasantness they've got. They're clearly not in a world of unpleasantness because they're falling asleep as soon as the nurse walks away from them. Or another example, it's the patient we get called to, can you go and see so-and-so who's had back surgery, they're saying their pain's 10 out of 10, and you go and see them on your ward round and the bed's empty, you ask the nurse where they've gone, they've gone out to have a smoke. And everyone's saying, well, the pain can't be 10 out of 10. They're not lying, they think it's 10 out of 10, but they're just telling you 10 out of 10 nociception. Okay, they're feeling a lot of stuff still, they're still feeling a lot of sensory stuff. They're not 10 out of 10 suffering, so they're telling you the truth if you actually ask them their suffering score or their unpleasantness score. It may be a 1 or 2, because clearly it's not troubling them that much, but they're worried about it. Okay, so it's very important that we as clinicians start to really appropriately assess patients and understand what it is that we're trying to assess. And this is the whole reason why, you know, in the US and other places they've brought forward a whole new scoring system where a number now has to be hung with or associated with a degree of unpleasantness. So you can only say your pain score is 10 when the pain is as bad as it could be and nothing else matters. So they're saying, let's attach an amount of unpleasantness to this pain score. It's not just, this is how we get around patients just telling us how much stuff they're feeling, how much sensory stuff they're feeling. Okay. I can't give this talk without mentioning the sphere of onco-anaesthesia, which is one of the big kind of buzz areas in anaesthesia. I'm not going to actually talk a great deal about it, other than just to mention about it. What's onco-anaesthesia? Well, onco-anaesthesia is this concept that the anaesthetic you give might alter the tumour progression or tumour recurrence. It stemmed initially from some laboratory research that showed that some of the drugs we use in anaesthesia, and for example the volatile anaesthetics, so the isoflurane, the sevoflurane, that smelly stuff the anaesthetist give, that they impair natural killer cell function, and natural killer cell function is very important for helping to prevent tumour recurrence. There was also some linking of the use of, well, that the opioids, particularly morphine, are angiogenic, so they encourage blood vessel development. All tumours require angiogenesis for that tumour to get bigger, so if you've got a drug that may be encouraging angiogenesis, there's a bit of a concern. And this led to a little bit of a flurry of some research, some clinical research, which did show an association between avoiding volatiles and avoiding narcotics or opioids and a reduction in tumour recurrence. So this sphere of onco-anaesthesia came out. And this is one of the first papers that came out. This was just an observational study looking at patients who had radical prostatectomies and looking at the two groups, those who got an epidural as part of their anaesthetic. So if you got an epidural, you needed less volatile and you certainly had much lower doses of opioids given to you, versus people who just got a straight GA and then got given a PCA afterwards. And you see quite a significant benefit in terms of tumour recurrence if you got an epidural versus if you're getting an opioid out at 6 years. But just an observational study. There have been other studies as well, breast cancer. So when you have breast surgery, it's quite amenable to the anaesthetist doing something called a paravertebral block, which is just a bit like an intercostal block but closer to the neuraxis, so you get multiple intercostal nerves. That leads to numbness in the area where the surgery is. If you do that as part of your anaesthetic technique, you'll be able to reduce your volatile and you'll be able to reduce your opioids. And when they looked at the outcomes for patients who had breast surgery, there was a paravertebral block, so at the top, versus standard GA with opioids, you again at 3 years, you saw a survival benefit for those who got regional technique. It's also been shown with colorectal surgery, if you get an epidural versus opioids, there's survival benefit. And this is a good study just to talk about briefly because it's only in a certain subgroup. The subgroup that got better, Group B, the people over 65, well, not got better, they had better outcomes were the people over 65. If you're under 65, having an epidural or not made no difference to tumour recurrence, but if you're over 65, having an epidural seemed to reduce your tumour recurrence. It's a complex area. It's not an area in which, we would certainly be saying, if you've got cancer, you must have a volatile free anaesthetic and an opioid-free anaesthetic. But it is a sphere in which people are seeing a lot of potential opportunity. And certainly I do know there are hospitals that will advertise, if you come to us for your cancer surgery, we'll promise you an opioid-free anaesthetic and recovery that's associated with better recovery from your cancer. There are other benefits, though, of doing regional anaesthesia that aren't just purely related to preventing tumour recurrence or just this onco-anaesthesia bit. So that's why I don't want to spend too much time on onco-anaesthesia, because there are other benefits. So this is quite a seminal paper that was published in The Lancet about 10 years ago from Widger, Sanjay and Beatty. 30-day mortality. They looked at about 70,000 patients in Ontario, Canada, and compared patients who had an epidural for their analgesia during surgery versus those who had opioid-based therapy, and there was a very subtle reduction in mortality. It's subtle because there's NNT down there of 500, so numbers need to treat of 500. You've got to put in 500 epidurals to save one life. So if you're that 1 in 500, you think that's great, get to go to Christmas with my family, but the other 499 are going, oh, well, that was a bit pain in the ass. So, but we got to kind of, the 499 did get other benefits that I'll talk about. When you focus more down on thoracic epidurals, so Widger, Sanjay and Beatty's previous study was all types of epidurals, including lumbar epidurals, so for hip or knee replacements, but when you focus in on thoracic epidurals, which an anaesthetist will provide, more for truncal surgery, which is in general a higher risk type of surgery, then we start to really notice the benefits of epidurals. And now we get a greater mortality benefit associated with epidurals, and our NNT now drops to 67. So I only need to put in 67 epidurals to save one life. Those 66 out of the 67 who don't get their life saved, they do get other benefits, and so if you just look at a plot of benefits, so anything that's on the left-hand side of this line is a benefit of the epidural, anything to the right is not a benefit of the epidural. So those other 66 will get benefits. They get things such as they're less sedated, they get less respiratory complications, so less pneumonia, such forth, and less cardiac complications, so fewer arrhythmias and fewer myocardial infarctions. So thoracic epidurals certainly are a big gun in terms of improving outcomes for our patients. Why don't we see thoracic epidurals being used so much, certainly in Australia? Well, a big reason for that can all be pointed at this thing called the MASTER trial, which anaesthetists will be well aware of. It garnered a lot of publicity because it was a major study conducted predominantly in Australia. It was published about 15 years ago, and it led to the use of thoracic epidurals, all epidurals in fact, falling off a cliff, as some people have said. What they showed in their randomised control study, which was quite a good design, they didn't really show the sort of mortality, well, they didn't show any mortality benefit of the epidurals, and they didn't really show a great deal of morbidity benefit like we've seen with subsequent studies. But because it was a local study, it carried a lot of power in terms of the practice of local anaesthetists. What is not so heavily emphasised, the major flaw of the MASTER trial was that only 50% of the epidurals actually worked. So they had a 50% failure rate. So they were comparing an intervention that 50% of the people didn't actually get the intervention, so it's not actually a very good study in terms of what you can interpret from it. When I do a lot of obstetric epidurals, if my obstetric epidurals failed at a rate of 50%, I would not be allowed to go back onto the labour floor, and yet this is a study that allowed a 50% failure rate. So that's the main thing that you need to take home from the MASTER trial, is we need to work a lot harder at making things work. If there's a benefit from it, you've got to make it work. So that's something that we've been doing at North Shore. So our success rate of thoracic epidurals, it's above college benchmarks. It's at 90%, so I'm not aware of any hospital that's able to achieve such a high success rate for the thoracic epidurals. Ours get to 5 days. The way we do that, it's a whole host of things we need to do to achieve that. For those who've never seen a thoracic epidural, that's one going into a patient there. You can see Richie's got some lovely pictures of needles being put into people's spine. He's got a CT and an MRI and all those sorts of things. That's fantastic. We don't have that. So you need, you're just going on anatomical landmarks. You need to be very proficient. So we've got 60-odd anaesthetists in our hospital. There's only about 4 or 5 who will regularly do thoracic epidurals. So one thing we've done is to quarantine who's going to do thoracic epidurals and who's not. The others will call upon people who do them regularly to do them for them. That's what a thoracic epidural will look like when it's done. It needs to be well affixated, which is one of the things we've done to make sure they work. Other things we've done, we've optimised our solution, so those that walk around the wards at North Shore will see that we're running this funny thing called a FAB solution. So we were the first hospital in Australia to routinely use this solution. It's a multimodal solution. It's got fentanyl, adrenaline, bupivacaine. The more drugs you put in, the less you need of each one of them and the better the analgesia, so that's why we're using the FAB. We're also the first hospital in Australia to pioneer the use of these CAD soluses to deliver what's called PIB plus PCEA. So what's that all mean? Well, rather than running a continuous infusion of local anaesthetic like we've classically done for the last 20 or 30 years, these machines are very clever. They actually deliver the drug as a bolus. So the standard setting, it delivers 4 mils every 30 minutes. What's the benefit of that? Well, if you deliver a drug as a bolus into the epidural space, you get much better spread. So you get multiple vertebral segments being covered by that local anaesthetic, and because it's being given in an intermittent fashion, you don't get accumulation of concentration, so you get a very dilute effect, and you're able to get fantastic analgesia with very, very few side effects. So these are things that you can do to optimise. One thing is that we're fastidious about. There's some ice there. Any of you wondering what on earth we're doing as anaesthetists? Every shift, a patient will get their epidural assessed. So the nurse has to demonstrate thermoanaesthesia, so they have to demonstrate anaesthesia in the area of that epidural to confirm that it's working. If it's not working, it's restored until it is working or it's taken out. Why do we do that? Well, because we can feed back then to the anaesthetist routinely, oh, your epidural didn't work or did work, and that's how you get your success rates up to the sorts of numbers that we've got. Another issue that does need to be discussed, a sort of elephant in the room, it's about the risk. Why don't we get epidurals being put in all the time? I did the ward round this week, and in fact I had a lot of patients that had major abdominal surgery and there wasn't anyone with an epidural in. There are complicating factors that we do need to talk about. One of the concerns about epidurals is the risk, and this will often come up in discussions with patients. So this was a big study, NAP3, which was a big audit of UK practice of several years ago. Just looked at the complication rates, so the risk of doing an epidural and some sort of harm because you are putting a needle into someone's spine, and what's the risk of that? You'll see in the obstetric population the risk is very, very low. This is per 100,000, 0.6 per 100,000. Once you do an epidural, though, in the perioperative group, your rate increases 10 times. Okay, why is there a big difference? The difference is these are healthy patients. Obstetric patients are young and healthy and fit. These are generally not young, healthy, fit patients. So it's not the needle going in, it's who you're putting it into. Interestingly, though, it's these people who will get the greatest benefit, though, of the epidural. So it's a risk-benefit thing. So, and you can do a risk-benefit thing, and the numbers come out very, very favourable. This is the way we do it at North Shore. We look at the risk of an epidural runs in the order of about 1 in 10,000, so 8 in 100,000 is about 1 in 10,000. Even if you just go on Widger or Sundrone Beatty's very conservative numbers of NNT of 500, that's very conservative. You can now come out that 500 goes into 10,000 20 times. So yes, you're going to injure one patient, but in that process of doing that, you will have saved 20 lives. Okay, that's a little bit of an ethical, difficult thing to, if you're that one person, that really sucks. Who's going to be that one person that suffers for the greater benefit? But the thing I would say, and that we say, well, what's the alternative? If I don't do that, what's the alternative? The alternative is I use opioids. And as we've just seen from the US experience, this attitude of just every problem is just a morphine deficiency state is causing real problems, and the use relying just on opioids, it does bring mortality benefits. So if you're going to do opioids instead, you're going to get probably similar mortality as associated with the use of opioids, but no benefits whatsoever. So that's things for us to be considering. And that, I'm pretty sure, yes, that brings us to the end of my talk. So I was really just wanting to introduce you to some of the ideas, some of the concepts that we're thinking about in anaesthesia and pain management, and where the challenges are for us and where we're moving forward into the future. Thank you for paying attention.